A battlefield surgeon wasn't always trying to stop you from losing blood. Sometimes he believed the only way to save your life was to take even more of it away. To a modern audience, that sounds impossible. A soldier already pale from a musket wound or shattered by artillery would seem to need every remaining drop. Yet for centuries, military medicine followed a very different logic. Across Europe, through the Napoleonic Wars, and even into parts of the American Civil War, bloodletting remained one of the most respected treatments a physician could offer. It was not considered desperation. It was considered science. The contradiction becomes even stranger when you imagine the scene. A wounded infantryman finally reaches a crowded field hospital. The smell of wet earth mixes with smoke, sweat, and iron-rich blood. Flies gather wherever bandages have been left too long. Men lie shoulder to shoulder, some crying out, others eerily silent. Surgeons move from table to table with astonishing speed, because dozens more casualties are waiting outside. The wounded soldier expects someone to stop the bleeding from his injury. Instead, the surgeon may reach for a lancet and deliberately open a vein in his arm, not because the wound required it, because the doctor believed excess blood inside the body had become dangerous. To understand why intelligent physicians accepted such a practice, we have to step into a world where disease looked completely different. Long before bacteria were discovered, before blood types were identified, before anyone understood oxygen transport or the physiology of shock, doctors were forced to explain illness using what they could observe with their own eyes. Fever, swelling, a flushed face, a racing pulse. To them, these signs suggested that the body contained too much excitement, too much heat, too much force. Removing blood appeared to calm the patient. The pulse slowed. The face became paler. Sometimes the patient even reported temporary relief. Those observations reinforced a belief that had already survived for nearly 2,000 years. The idea originated largely from the teachings associated with ancient Greek medicine, especially the tradition of Hippocrates, and later expanded by Galen. Their theory held that health depended on the balance of 4 bodily humors: blood, phlegm, yellow bile, and black bile. Disease was thought to result from imbalance, and removing blood was one of the most powerful ways to restore harmony. This framework dominated European medicine well into the 19th century, despite growing challenges from newer scientific discoveries. Historians of medicine, including Roy Porter and scholars writing for the Wellcome Collection, describe just how deeply this tradition shaped medical education and battlefield practice. The soldiers rarely questioned it. Why would they? The surgeon had years of training. The procedure had been taught for generations. Officers, civilians, and even kings had undergone bloodletting. It carried the authority of established medicine. But the battlefield exposed one devastating flaw. Many wounded men were not dying because they had too much blood. They were dying because they had almost none left. And before doctors understood that difference, thousands of desperate patients entered field hospitals only to face a treatment that could quietly push them even closer to death. But recognizing that mistake would require overturning nearly 2,000 years of medical certainty. For nearly 2,000 years, bloodletting survived not because doctors were cruel, but because it often looked like it worked. That illusion made it one of the hardest medical traditions to abandon. Imagine standing beside a surgeon during the Napoleonic Wars. A young soldier is carried into the dressing station with a high fever after a musket ball shattered his leg days earlier. His face is flushed, his skin is hot, his pulse pounds beneath the surgeon's fingers. To modern medicine, these are warning signs of infection and inflammation. To the physician of the early 19th century, they suggested something entirely different. The patient's circulation appeared too forceful. The body seemed overwhelmed by excess blood. The obvious solution, according to accepted medical teaching, was to reduce that pressure before it caused even greater harm. A shallow cut opened a vein at the elbow. Dark blood flowed steadily into a waiting bowl. The surgeon watched carefully, not for a laboratory value or blood pressure reading, but for changes in the patient's appearance. A softer pulse, a paler complexion, less agitation. These visible changes were taken as proof that the treatment was succeeding. The problem was that the body was quietly entering an even more dangerous state. Today we understand that severe injuries trigger a complex physiological response. Blood loss reduces oxygen delivery to vital organs. The heart works harder to maintain circulation. The immune system launches an intense inflammatory reaction to damaged tissue and invading bacteria. Removing additional blood from a patient already struggling to maintain circulation can worsen shock, reduce oxygen delivery even further, and increase the risk of organ failure. But none of that knowledge existed. William Harvey had demonstrated that blood circulates continuously through the body in 1628, overturning many earlier assumptions. Yet Harvey's discovery explained how blood moved, not fully how much the body could safely lose, or how blood loss affected survival after trauma. Even as anatomy advanced, centuries-old therapeutic habits remained deeply rooted in medical education. This gap between new discoveries and everyday practice proved deadly. Military surgeons worked under relentless pressure. They had no antibiotics, no intravenous fluids, no blood banks, no sterile operating rooms. They judged patients almost entirely by what they could see, hear, and feel. Sometimes after bloodletting, a patient became quieter, less restless. His pulse slowed. To exhausted physicians, that looked like improvement. In reality, he might simply have become too weak to struggle. There were, however, observant doctors who began to notice uncomfortable patterns. Some wounded men who had lost little blood from their injuries survived despite severe fractures. Others, whose bleeding had been treated with additional venesection, declined rapidly. Their skin turned cold and damp. Their breathing became shallow. They drifted in and out of consciousness before dying hours later. These observations did not immediately overturn established doctrine. Individual cases could always be explained away. Perhaps the wound had been worse than expected. Perhaps the patient's constitution had been weak. Perhaps the disease itself had been unstoppable. The theory survived because it always offered another explanation. Medical historians have shown that this persistence reflected more than stubbornness. Bloodletting was supported by respected textbooks, influential physicians, and generations of clinical teaching. Challenging it meant questioning the very foundation of Western medicine, a step few practitioners were willing to take without overwhelming evidence. Meanwhile, the battlefield kept delivering that evidence. Every campaign produced thousands of shattered bodies. Every crowded hospital became an unintended experiment, and among the screams of amputations and the smell of infected wounds, a handful of surgeons began asking a dangerous question. What if the treatment itself was helping to kill the men they were trying so desperately to save? The answer would emerge not in lecture halls, but inside the chaotic field hospitals, where every minute forced doctors to choose between tradition and survival. The field hospital was rarely quiet. It echoed with saws cutting through bone, boots splashing through mud tracked inside from the battlefield, and the low murmur of surgeons making impossible decisions in seconds. Outside, stretchers kept arriving. Inside, there was never enough space, enough light, or enough time. For the wounded soldier, reaching the hospital did not mean the danger had passed. In many cases, it had only changed. A surgeon's first examination was brutally simple. Could the limb be saved? Was a major artery damaged? Was the patient still conscious? Without X-rays or modern monitoring equipment, everything depended on experience and observation. A man who looked pale and weak after heavy bleeding might still be given a small amount of bloodletting if the surgeon believed fever or inflammation posed the greater threat. Others underwent the procedure before an amputation because some physicians thought reducing the force of circulation would lessen complications during surgery. Then came the operation. An assistant gripped the patient tightly, while another held the injured limb. General anesthesia was unavailable until the widespread military use of ether and chloroform in the mid-19th century, and even then, supplies could be inconsistent depending on the conflict and location. Earlier, soldiers often endured surgery fully awake. Later, some were fortunate enough to inhale anesthetic vapors, slipping into unconsciousness before the knife touched skin. The surgeon worked with astonishing speed, not because haste was admired, but because every extra minute increased the chance that the patient would die. A circular incision separated skin and muscle. The soft tissues were pulled back. A bone saw bit into the exposed limb with a harsh, rasping rhythm that could be heard throughout the tent. The remaining blood vessels were tied off with silk ligatures before the wound was covered with linen bandages. The operation itself was often successful. What followed was far more unpredictable. Within days, many wounds became swollen and intensely painful. The edges darkened. Thick yellow or green pus seeped through stained bandages. The smell changed first. A sickly, sweet odor recognized immediately by experienced hospital staff. Then came fever, confusion, and exhaustion. Doctors gave these conditions names like hospital gangrene or pyemia, but they didn't yet understand their true cause. Today we know these infections were usually caused by bacteria spreading through contaminated instruments, unwashed hands, reused bandages, and overcrowded conditions. Joseph Lister's antiseptic techniques would not begin transforming surgery until the late 1860s, after drawing on Louis Pasteur's work demonstrating that microorganisms, not bad air alone, played a central role in infection. Before that revolution, a surgeon might wash visible dirt from his knife, then use the same blade on the next patient, not out of negligence, out of ignorance. Many hospitals believed foul smells caused disease rather than resulted from it. Windows were opened for fresh air, but instruments were rarely sterilized because the invisible world of microbes had not yet entered everyday medical practice. The tragedy was that surgeons were often extraordinarily skilled. Many could complete a life-saving amputation in just a few minutes. They possessed remarkable anatomical knowledge and steady hands developed through years of experience. Yet their greatest enemy was one they could neither see nor imagine. And while infection claimed countless lives, another silent killer continued its work alongside it. Shock, not emotional shock, but the body's catastrophic response to severe injury and blood loss. Modern trauma medicine recognizes hemorrhagic shock as one of the leading causes of preventable death after major injuries. Without enough circulating blood, organs are starved of oxygen. Blood pressure collapses. The heart struggles to compensate. Eventually, even if the wound itself is controlled, the body begins to fail. To physicians who still trusted bloodletting, this decline could be tragically misunderstood. The patient seemed restless. They removed more blood. The patient became quieter. They believed the treatment was working. By the time they realized he was slipping away, there was almost nothing they could do. But across Europe and America, a new generation of researchers was beginning to challenge these old assumptions, and their discoveries would change battlefield medicine forever. The end of bloodletting did not come with a single discovery. It came with a growing pile of patients who refused to fit the old explanations. For generations, physicians had trusted what they could see. A flushed face meant too much blood. A racing pulse meant excessive excitement within the body. If removing blood appeared to calm those symptoms, then the treatment seemed justified. But by the middle of the 19th century, something was changing. Doctors were beginning to measure instead of simply observe. Autopsies became more systematic. Hospitals kept better records. Medical journals compared outcomes between different treatments. Slowly, patterns emerged that were difficult to ignore. Patients who survived major injuries often had one thing in common. They had managed to keep enough blood circulating through their bodies. This realization was strengthened by advances in physiology. Scientists were uncovering how the heart functioned as a pump, how blood carried oxygen and nutrients, and why severe blood loss could trigger the collapse of the body's vital organs. The circulation described by William Harvey centuries earlier was finally being connected to what surgeons witnessed every day beside the operating table. The old theory of balancing humors was becoming harder to defend. Then another revolution arrived. In the 1860s, the British surgeon Joseph Lister applied Louis Pasteur's research on microorganisms to surgery. If invisible microbes caused wounds to become infected, then surgeons might prevent disease by destroying those microbes before they entered the body. Lister began using carbolic acid to clean instruments, dress wounds, and disinfect the operating area. The results astonished many of his colleagues. Patients who would once have developed overwhelming infections now recovered in far greater numbers. Hospital gangrene became less common where antiseptic methods were adopted. Mortality after surgery began to fall. Not every physician accepted these ideas immediately. Some dismissed antiseptic techniques as unnecessary. Others argued that invisible organisms were merely another passing theory. Medical history rarely changes overnight. Old habits survive because they are familiar. Yet every successful operation performed under cleaner conditions made it harder to defend the older practices. At nearly the same time, doctors were also rethinking blood itself. For centuries, blood had been viewed largely as one of the body's four humors. Now it was increasingly understood as an irreplaceable tissue with specific functions. Losing too much of it was not simply weakening a patient. It was depriving every organ of the oxygen needed to stay alive. There was only one problem. Even after physicians realized that patients desperately needed blood, they still had no safe way to replace it. Early transfusion experiments had been attempted as far back as the 17th century. Some involved animal blood. Others transferred blood directly between people using crude equipment. The results were wildly unpredictable. Some patients improved briefly. Others suffered violent reactions that physicians could not explain. The missing piece remained invisible. No one yet knew that human blood existed in different types. That mystery would not be solved until 1901, when Austrian physician Karl Landsteiner identified the major ABO blood groups. His discovery explained why some transfusions succeeded, while others proved fatal, laying the scientific foundation for safe blood transfusion. Decades later, improvements in blood storage, anticoagulants such as sodium citrate, and organized blood banks transformed emergency medicine, particularly during the World Wars. Military surgeons had spent centuries trying to save wounded soldiers with the tools and knowledge available to them. Many were compassionate. Many were exceptionally skilled. But they were trapped inside a medical framework that misunderstood the body's most vital resource. As the 19th century drew to a close, that framework was finally collapsing. Yet one final breakthrough would completely transform the fate of wounded soldiers. For the first time in history, doctors would no longer be forced to watch helplessly as life drained away. They would discover a way to give it back. For thousands of years, a battlefield wound carried a terrible second danger. Even if the bullet missed your heart, even if the sword avoided your lungs, your greatest enemy might still be the treatment waiting for you. That is the paradox at the heart of military medicine. The surgeons who bled wounded soldiers were not trying to hasten death. They believed they were preventing it. They worked with extraordinary dedication, often standing for 20 hours or more without rest, surrounded by endless rows of casualties. Their aprons stiffened with dried blood. Their hands ached from tying arteries and sawing through shattered bone. Every decision had to be made with incomplete knowledge. History has judged some of those treatments harshly, but it has also revealed something more important. Medicine advances because its own assumptions are constantly challenged. The 20th century brought breakthroughs that earlier generations could scarcely imagine. Karl Landsteiner's discovery of the ABO blood groups made compatible transfusions possible. During the First World War, physicians learned to preserve donated blood using anticoagulants, such as sodium citrate, allowing it to be transported rather than transferred directly from one person to another. By the Second World War, organized blood banks, improved surgical techniques, antibiotics like penicillin, and better methods of treating shock dramatically increased survival among wounded soldiers. A casualty, who would almost certainly have died on a battlefield in 1815, or even in 1863, might survive a similar injury today. Modern trauma teams do not remove blood to restore balance. They fight relentlessly to preserve circulation. Emergency physicians measure blood pressure, oxygen saturation, and blood chemistry within minutes. Intravenous fluids stabilize patients, while compatible blood products replace what has been lost. Surgeons repair damaged vessels under sterile conditions. Intensive care units continue that battle for days or weeks, supported by antibiotics, advanced imaging, ventilators, and continuous monitoring. The difference is staggering, yet the goal has never changed: to give a wounded human being one more chance to live. Looking back, it is tempting to see the surgeons of earlier centuries as reckless or misguided. But that would overlook the reality they faced. They operated without microscopes capable of revealing bacteria. They had no understanding of blood groups, no refrigeration for blood storage, no laboratory tests, and no antibiotics. Every lesson had to be learned from experience, often paid for with countless lives. Many of the practices we now consider obvious were built upon those painful failures. Every discarded theory, every improved instrument, every scientific discovery, every carefully recorded case. Together, they transformed medicine from tradition, guided largely by observation, into a discipline grounded in evidence, experimentation, and constant revision. That transformation continues today. Modern physicians still question established treatments. Clinical trials still overturn long-held beliefs. Medical knowledge remains a process, not a destination. The difference is that today's conclusions are tested against rigorous evidence rather than accepted, because they have been taught for centuries. The old field hospitals have long since disappeared. The muddy tents, the piles of blood-soaked bandages, the bowls collecting blood that surgeons believed needed to be removed. They remain as reminders of a time when compassion alone was not enough. Without scientific understanding, even the most sincere efforts could produce devastating consequences. Perhaps that is the most remarkable part of this story. The greatest breakthrough in battlefield medicine was not a sharper scalpel or a faster amputation. It was learning that sometimes the oldest certainty can be the deadliest mistake, and that replacing blood, rather than taking it away, would become one of the greatest life-saving advances in medical history. The next time you hear about a modern trauma patient surviving injuries once thought unsurvivable, remember the generations of soldiers whose suffering slowly revealed the truth. Their stories helped shape the medicine that millions of people now depend upon every day. If stories like this remind you how extraordinary modern medicine really is, consider subscribing so you won't miss the next forgotten chapter of history. And if one part of this story surprised you the most, leave a comment below. History often hides its greatest lessons in the places where science was forced to learn them the hard way.